CHAMP project in terms of its results. So we're glad that you're here to hear the innovative and groundbreaking work that we've done and the future directions of CHAMP. So my name is Dr. Kenneth Fong, and I'm a psychiatrist. And I'm also an associate professor with the Department of Psychiatry, University of Toronto, and the clinical director of Asian Initiative in Mental Health. And in the context of this research project, I'm one of the co-principal investigators of the research. And my role here this morning would be to be the moderator and introduce you to the amazing speakers we have on this panel, and to direct any of the hard questions to everybody on our left. So to begin with, our first speaker will be my colleague and also co-PI of the project, Dr. Josephine Wong, Associate Professor of Nursing from the from Ryerson University.
Okay, thank you. So I'm just going to provide a little bit background about HIV stigma as well as this research. So since the early 1990s, research has shown that HIV stigma and discrimination create immense obstacles to HIV responses. Fear of being ostracized, rejected and oppressed by others prevented people from getting tested or seeking treatment and care even if they find out that they're HIV positive. One of our previous studies showed that HIV stigma perpetuates the invisibility of HIV issue and people who are living with HIV. And when that issue becomes very invisible, then it perpetuates denial and silence in our communities, which reinforce further stigma and discrimination. The impact of HIV stigma and discrimination even more negatively impacting our communities because we already had to face other discrimination such as racism, economic marginalization, and inequitable access to other resources like education and employment. So responding to the need of addressing HIV stigma, which is identified by people living with HIV as well as our community stakeholders, we developed CHAMP, which is an initiative that is innovative in bringing different leaders from different sectors, such as the faith-based, media, social justice, settlement, and health, into this study, as well as working with people who are living with HIV. We tested two interventions to see whether they are able to reduce stigma. One is called acceptance and commitment training that promotes psychological flexibility so that people who are living with HIV are better able to actually address the kind of shame or fear that is imposed on them by others. And we also test another empowerment initiative and training called social justice capacity building that supported all our participants to become more knowledgeable, active, and increase evidence to address social justice as well as HIV issues. So the result of our study has shown that our interventions are effective. Our quantitative data show that there is definitely significantly reduction in both internalized as well as enacted stigma. And our qualitative data show that people are better able to actually address issue in the community, including disclosing to their family, speaking out in the community. Then we have also other evidence which is very groundbreaking in a sense that we capture not only change in attitude and behaviors, we also capture that our 66 participants had actually taken 1,090 activities in reducing HIV stigma as well as promoting social justice in other issues. So now I'm going to pass the talk to our good friend, Ivana. And Kenneth might say a little bit about who Ivana is.
So Ivana, because as you heard about the project called CHAMP, so actually our focus then is on developing champions. So the participants who are going through our research study, they get trained and they become our champions, and they are the engine, they are the people, the stars of the study, and they are the ones who did the 1,000 plus activities. And so today we are really happy to have with us two of our participants of the research study, so they are the champions of the study, that they can give you a first-hand account of the kind of experience they have with the research study and also the kind of stuff that they have done. So we'll turn our attention to Ivan.
Good morning, everybody. I'm Ivan Ortigosa. I'm a trans woman of color. I live with HIV for 16 years now. Before I meet Champ, I was a person who had a lot of stigma. Not because the HIV, but was more because I'm a trans person and I have to do like double stigma. So for me, it was a very heavy weight in my shoulder. So a few years after I introduced myself to Champ organization 5 years ago, and I started with them the project and the research. And today I can tell you, because of them, I don't have any stigma in my life. I'm very open with my HIV. I'm very active with HIV. Right now I do a research for HIV and trans women and elderly women with the University of Concordia, and will be a national survey, so to make better life to trans person. So that I owe it to them, because if I never be the student with them, I never be able to get all these goals I have in life, because I was too fear to come out as a HIV person. But I don't mean I'm not gonna die tomorrow. I'm undetectable. I'm healthy like a bull. Thanks to them, because after I did the research with them, I started sleeping better, take care of myself better, and to love myself better, to love my HIV. So thanks to them, I'm here today, and I do a lot of things for the community. And I respect in my heart, these people have a special place. So, thank you. I don't want to cry. Thank you.
So, thank you very much, Ivanis. So, you can see how special this press conference is, because usually it's only the researchers that get the spotlight, but here you can see that the spotlight also is our participants, people who come through the study and become champions of the study. And you just heard people with HIV engage in the study and the transformation through the study that they can undergo, and the power they have inside them and the strength they have inside them can really come out. And now we're going to hear another of our participants, Pinky, who also had been part of our project as a research participant, so she's another champion.
Thank you. When I was recruited to participate in the study, I didn't expect anything like this big. So I have no expectation at all. But and I thought that it would be very easy for me to just answer the questions, you know, check all those papers that was given to us. But the experience actually helped me to learn a lot about the HIV stigma. It came to a point that I became very, I would say, uncomfortable, because I thought I knew about it, I read about it, but it became uncomfortable because I never learned about the struggle of many HIV positive person that I didn't know was also part of the study. And this feeling of being uncomfortable is actually coming from this word. I don't know a lot about the people who experience it and about the HIV itself. So I learned a lot from the study, and I'm very thankful to be part of this CHAMP study. And it helped me to learn not only about their struggle, but my own struggle, my own ignorance about the issue. And what made me what helped actually to make me realize this is the mindfulness training and the social justice activities that we did. It helped me understand not just the struggle that we are all facing, but actually to name that struggle that each of us, me as a migrant worker, as a colored woman, that it has a name, and that is a stigma. A stigma that prevents us from reaching out to each other. And it's also the stigma that divides us instead of, helping us to come together as a community and face this HIV thing. I made friends with some of the participants in the study, and honestly, I learned to like them. I learned to love them because there's another person in front of me, just like my sister here. It's very real. The experience of touching them, hugging them, and hearing their story. It's very empowering for me because it's not just that I learned about their struggles, but I also learned about my weaknesses as a person. And I also celebrated with them, not just the weaknesses that I have, but also the strength in coming out, in the community as an ally for these people who identify themselves as positive. I believe that that we can erase all the stigma and discrimination that our community is facing, regardless if they are HIV positive or other people who are experiencing stigma and discrimination. We as a people, all the participants of the study, I would say that we can help in the prevention of the disease. We can help participants or people who came out as positive to access treatment and care. And best of all, most of us who came out who are not HIV positive, but we came out as a support and ally for these people and friends. The study evolved to something more tangible for every one of us because we were able to create ideas and put them into action by creating films, activities, community activities that actually help us to come together, not as an individual, but as a community. And it only proves one thing, that we can unlearn our prejudices and our ignorance. And I know that together, as a community and as a group, we can make changes.
So thank you, Pinky. So as you've heard, then Pinky is not only a CHAM participant, she's actually a community leader, well known in the Filipino community, championing for the rights of the Filipino community and also migrant workers. So she's a very active person, and through this study, you can see the fruits of the study in which the participants can sit side by side and become good sisters through the study and do community work. People with HIV, people without HIV, community leaders from different ethnic groups coming together. So this project is all possible through the different kinds of interventions of CHAM, including ACT and SJCB, Acceptance Commitment Training, and Social Justice Capacity Building. There are many different moving parts, and it's a very complex study. So to hold this all together, we need a super project coordinator, and that's, you're going to hear from next, Henry Loya. He is our super research coordinator, who's been able to, in the last 3-4 years, hold together a really complex project, delivering an intervention that we have designed. This is really truly innovative, and then go on to really capture the data. So Henry's going to take you through some of the highlights of that process.
Thank you. Good morning, everyone. As a coordinator of the CHAM study, this was an experience for me to learn, but at the same time work with the peer research associates throughout the process of the research. From recruitment to confirmation of participants, because it was a multi-year study, there was a lot of phases as well as a lot of commitment in terms of time for the participants. And so during the actual study, I was able to work with 5 to 6 peer research associates. So even though I was a coordinator, actually I was working with the peer research associates to gather a lot of data, but also to engage with the many participants that we engaged with for several years. One thing that struck out most for me is the degree of commitment from my peers. It supported the disclosure of HIV status, but also I continued to learn as a person and also to grow in terms of learning how to coordinate a study, but also translating some of the knowledge findings into action. This process supported me and my peers to sort of take on leadership roles in the community to challenge stigma as well as denial and silence. Because stigma creates a lot of collective silence. People don't want to talk about the issue. So this was a chance for me and my peers to take on that leadership role, to say that we are a collective, we're a community, we can address HIV stigma and other social justice issues. On a personal basis also, I was able to gain skills and also aspire to gain more by returning to school and get more of the professional learning, if I may say, to increase my capacity to do community engagement and community research. So, in a nutshell, I feel that the engagement of community leaders living with HIV and allies who are from the faith community, the media and arts and social justice sectors really brought the whole thing together in terms of working collectively to address HIV stigma. Thank you.
So thank you, Henry. So you can hear the kind of some of the work that Henry has done in pulling, coordinating the project as a peer research coordinator, working with the peer research associates. So some of the principles behind the research study then is having people with experience with HIV, having HIV be the leaders of the study, such as Henry, so that we can really involve and engage the peer community, meaning that people with HIV gets involved in active research and care for people with HIV. So now, last but not least, we'd like to introduce to you the nominated principal investigator, the NPI of the research study, Dr. Alan Lee. He's an HIV primary care physician with the Regent Park Community Health Center, and he's the NPI of the CHAP. And he's also with the Committee for Accessible AIDS Treatment. So being an NPI means with the three of us working together, he's like the lead, taking charge of everything, and being an advocate for HIV for many, many years. He says go on because the CV is very long. So being an advocate for many years, he will share with us some of the highlights of this study and what's unique in this study among all his other efforts.
So thanks very much for joining us here today. It's actually a very proud moment for our community, having done really, really hard and groundbreaking work for the last 3.5 years. I think what we are most proud of CHAMP is not only is innovation in research, not only the fact that it brought different communities together, but more importantly is the collective commitment that we're gonna do tangible, sustainable community action beyond the life of the research. Most research, they might find important information or generate exciting knowledge, but a lot of times those knowledge may not translate to actual practices in the communities. So they have brilliant reports that sits on the shelf, and it might benefit some people, but the people who were part of the research may not actually get to enjoy the fruits of those studies. So as CHAMP is a community-based action research study, we have made that commitment from the very beginning that we need to make sure whatever we learn from CHAMP will be used in the communities that we engaged in. So I wanted to talk a little bit about what actually happened and what are happening beyond the completion of the official research study. Because I think through CHAM, we have created a community that are sustainable, that are committed to carry out the actions together. In terms of, and we've done a lot of work within the HIV sector as well as beyond the HIV sector. So within the HIV sector, amongst the people living with HIV participants, we have actually supported a lot of community champions who have done amazing work since their participation in CHAM. We have leaders who have helped co-founded the Canadian network of HIV positive people. We have started a new group of Ontario positive Asians who has, up to this last year, have never had any visibility within the Asian community, and those are found by our champs. So I'm very proud of that, and many of our peers have taken on leadership positions in the African Caribbean communities, in the Latino communities. So, and Ivana, has done amazing work across different communities, with trans community, with the Latino communities as well. So, within the broader HIV communities, we've also been able to adapt the CHAM intervention to help develop different programs. We have a program that supports people who have issues, challenges with mental health and addictions. We've been asked to do training for African and Caribbean community workers across the province on our stigma reduction strategies. So those are very exciting response from the community that shows that our work has generated a lot of interest and is being taken up by the communities. We've also formed a community alliance with all the existing multicultural, ethno-racial AIDS service organizations, plus some faith-based organizations, to look at future funding and integrating the CHAM interventions from being a research intervention to actual programming in the communities. So those are very exciting things. And beyond the HIV sector, we are also very excited that a lot of times HIV is perceived as a very marginalized or other issues, that whatever we learn about HIV is only relevant to HIV. But it's through our community engagement and through our multi-sectorial partnerships that we've actually been able to effect a lot of changes. So one obvious example is the fact that some of our research team members, Dr. Josephine Wong and Dr. Kenneth Fong, was able to build another partnership with universities and CAMH to launch another study to address, using the CHAM interventions to address mental health illness stigma in the Asian communities. And that Strength in Unity project has received $3 million funding from the Movember Foundation. So, and it's going to engage, over 2,000 participants across Canada. So you can see that the CHAM research not only benefits the HIV community, but also actually benefit much broader communities across Canada. And we believe that with a lot of our champions who have multi-community and also international connections, we will be able to use the CHAM learnings to benefit communities worldwide as well. So going forward, we look forward to having ongoing partnerships developed, and we're looking forward to learning more as we roll out the CHAM interventions in the community programming. So thank you very much for coming, and we'll pass it back to Kenneth to see if you have any questions. Thank you.
Thank you, Dr. Lee. So as you can hear, as Dr. Lee highlighted, that CHAM is a groundbreaking study. It has great contributions to the scientific community because of the research methodology. So scientifically, it's very amazing. But also, because it's a community-based project, the actual work that's been done benefits the community directly. And then what Dr. Lee highlighted, there's also the impact of the study beyond just the direct people who have been involved with this study, but with far-reaching consequences and positive impact that pushes the agenda forward in the community in other ways, and then finally beyond the HIV community. So and that's a summary of what the message we want to, the good news we want to convey to you today, and we would like to open up the floor for questions.
Any questions or comments? Yeah.
Thank you very much for inviting me for this groundbreaking strategy intervention. But before I ask the question, I think I should give my background. I'm sitting here. So I'm a medical doctor and I have my master's in epidemiology, and my PhD was focused on social determinants, and I conducted a huge community study in Pakistan's city of Karachi. It's a very cosmopolitan city, and conducted study of young adults basically to get the knowledge about the HIV/AIDS. And the bottom line was that the two things that came very strongly was one was the lack of parental communication, and the second was the stigma. So I believe that with this study, I think stigma is not only to get access to the treatment, but also to have the social communication and the social setup in there. Specifically in the newer environment when the people are coming here, they're mostly the immigrants, the marginalized and the vulnerable population. My question is regarding this study. I have a couple of questions which is mostly related to the methodological aspects of this study, which I get that this is a sort of a quasi-experimental design or intervention that you are comparing two groups and those who are. In your research question, you said that you would like to see the difference between the two groups, but in the analysis you said that there wasn't any power of the study, that you combined these two groups and you just showed the table in terms of the mean, that how the mean is changing, the trend of the mean in different three waves. So my question is, do you think that the sample size was adequate for this study to reflect and to see the difference in the two groups? And the other question is related to the qualitative study, that because you have the quantitative analysis as well as the qualitative. But in the qualitative, I was unable to get the feel that what type of content analysis have you done, or what theme was coming out, and how you assess because most of them are narratives. The narrations and the saying from these participants. So these are the two major big questions, but there are a couple of others, but I think I would restrict myself to these two.
Okay, thank you for that question. And just hearing from your introduction, you belong to CHAMP, and we welcome you to join our cause, given your expertise. Maybe I can start to answer the question about the methodology from the quantitative aspect, and I will invite maybe Josephine then to comment on the qualitative aspect, and then Alan finally to follow up with some thoughts. Would that be okay? So to start with the quantitative aspect, what we have done is that we have recruited two groups of people, and both groups of people received social justice capacity building training, and one group have received acceptance commitment training. So what we were looking at is whether there were differences between these two subgroups. In other words, both have received SJCB training, but only one group has the additional ACT. So the study, you're right, is that we did not find a difference between the two groups. But what we were able to show was that there was a significant difference statistically between pre and post, and also between pre and follow-up, which is like 9 months later, which means that all participants improved. And there are many reasons for this. And I think certainly one of the reasons is that because both groups have improved so much, because it's not like we're comparing one group versus a placebo, so to speak, inactive group. Both were active groups. So what we were able to show is that the interventions we provide did something. What we didn't show the difference is whether one group is better than the other. In other words, it seemed like that both groups had improved in one aspect, which is the stigma, which is a measured construct, both in terms of internalized stigma for people with HIV, as well as external and active stigma for people without HIV. So there is a convergence of data which suggests that the data, both the fact that there was a reduction of stigma between pre and post, not only that, it is sustained with strong evidence that the intervention did do something. Secondly, in terms of the 1,000 activities that's logged, it's also a behavioral measure, if you will, which is innovative aspect of the qualitative-quantitative divide of how our champ is receiving the study. Not only did they say on paper from a research quantitative scale that, oh, I feel better about things, they actually did do something about it, and that's documented. So we take that as evidence that both of our intervention, which is SJCB alone and SJCB with ACT, has together been able to push people forward. And so at a quantitative level, the two groups are hard to distinguish because both groups did well. So to understand that, it would be to kind of say we're comparing two active treatment. In other words, we're kind of comparing almost like aspirin and Tylenol. We found that they both reduce headaches. But we can't say definitively one's better than the other, but they do something different, and yet they both improve. So the question is, how are they subtly different? Because they both achieve good outcomes. And I think this is where the mixed methodology helps, and Josephine will tell you that the qualitative aspect illuminates that in fact they are subtly different and that they achieve, even though what looks like the same outcome, but maybe through different factors.
So CHAM is actually very innovative and smart in a way that because of our methodology. So instead of relying on scales that measure, what counts, but we don't understand why it works and what's going on. So in qualitative research, we are not looking at, how is it generalized across, thousands of people. We're looking at what actually did happen. And in our qualitative data, it shows that people who actually had demonstrated that when they were engaged, those who engage in ACT on top of, SJCB, they actually talk about the different activities that actually help them. We have one participant who had experienced depression for many, many years, who had disclosed to family, but he said that every time he used to talk to his family back home, he felt shame. And it's because of ACT, the mindfulness, the labeling, they even identified the activities, what liberated them. So that now when he called home, he did not feel that sense of shame, and he talked to his family differently. And so, and this participant at 9 months talked about how he wasn't involved with the community, and then he actually went on and took leadership role in the community, in the HIV sector. Then we have non-PHA people who are not living with HIV, and they took part in the SJCB, and they were able to name activities that actually enabled them to see, wow, we're all actually experiencing different kinds of oppression, and now I realize that I develop empathy for others, and then they become collective. It also addressed the internalized stigma, because many of our participants are racialized people. And so how it addressed the stigma is not HIV stigma, but actually the stigma of racism, the stigma of speaking with a different accent. So we were very innovative in a way that we go beyond using scales, capture the rich data, and then on top of that, we integrated the health promotion, evaluation mechanism, and capture the action. In terms of, you talk about 66 people, isn't that not enough people? We actually anticipated, because it's an intervention that requires some people to come through 11 sessions with us. So we anticipated that there will be dropout. So we actually had recruited and engaged 104 people to actually sustain the 66. And then some of them even between 3 months to 9 months, they leave because beyond the circumstances of the study, one was deported, one was moved to another country, right? So the good thing about it is because CHAM is a first project to look at all this issue and pilot it. So what we have been able to use is what we learned to translate into another intervention, and that one, we had a lot more money because we only had 3-year funding. There's not sufficient resources, but that one we will have 1,500 people across 3 cities in Canada to look at how a similar model, with ACT being the same, is going to influence mental illness stigma. So stay on, we'll continue to let you know.
Yeah, so the next study, power will be a lot more with over 1,000 participants. So Dr. Lee, did you have any additional comments?
I don't really have much to add. I think what we wanted to learn from the study is not necessarily just one is better than the other, but what each of those interventions can contribute to the overall reduction of stigma and community mobilization. And I think the skills is something that would enable, I guess, policymakers and quantitative researchers who likes to look at numbers to get some reassurance that we actually show statistically significant changes. But the qualitative data and the thematic analysis based on our focus group, based on people's testimonial and activity log, actually, we were able to pull out those thematic trends of, what differences has it made in people's lives, what types of activities people are engaged in, how did they see issues differently, and how do, what kind of initiatives contribute to stigma reduction. So for example, we can see that in people with HIV, one of the key challenges we wanted to overcome is the invisibility and the oppression of people with HIV in our communities. Right? And we believe, and from previous research, have shown that their invisibility is a critical barrier to the broader community understanding and empathizing with the relevance of HIV stigma in our communities. So by having many of our participants disclosing their status with their family, in their community, speaking up in church to their religious leader, challenging the professors in class, those made a huge difference, right? And we were able to document that through the qualitative discussions. So I think, and we didn't want to do a control group for many reasons. One is resource, but also I think we need to recognize that HIV has contributed a lot of groundbreaking things in terms of research. One of the things about HIV activism is that we do not support the notion of placebo, because people with HIV were dying at the beginning of the epidemic because we had no access to treatment, and for medical scientific community to conduct research with the traditional model of having something that we think will work versus something we know is just a sugar pill is totally unacceptable and unethical. So in planning our intervention, given the limited resources we have, we need to respect the fact that we believe both of these interventions have merits and both of them will contribute to different things. But rather than giving one group an active intervention and one group almost nothing, we believe that we at least need to commit to, like the basic, positive interventions to support people's and to honor their commitment and time, because we are a very heavily committed kind of research studies. As Josephine said, most of the participants has to attend at least 5 sessions, and some of them need to attend like as long as 11 sessions. So for a lot of our people who are already very active in the communities,
it's something that we welcome, and we actually are working with different agencies to actually have that kind of discussion so that we can tailor that program. And so the 9 months in the CHAMP was in some way very valuable in the sense that really showed the amazing work that our peer research associate had done. Many of them are here today. And so they held cafe drop-in, so people can come and talk and report what activities they're doing, but that would need to do when it's a program at the front line.
And certainly it's very flexible. So the principles behind CAAT, for example, even in the literature, not only for this, but in other kinds of psychological issues, can be one session of 1 hour to many hours. So if it's an agency in terms of programming, it can be integrated so that it can be tailored to what you need. It can be a 1 hour, one-off thing. It could be a monthly 1 hour thing, or it could be an unending thing based on principles. So it's highly flexible and adaptable.
and we're also looking at having the core module and then also additional follow-up work. So you might have a 2-day session and then follow it up with another session 3 months later. We're also developing training resources online and through webinars and other technologies so that we can reach a wider audience. So all of these are, things that are evolving, and we're engaging the communities to co-develop as we go along. Because, there's no one-size-fits-all thing, but I think what helped one of the key lessons we learned is that there are really core elements that enable that understanding and development of empathy, compassion, and camaraderie amongst communities. And that is one of the key motivating forces of anti-stigma and community mobilization work. So there are some core elements that we want to ensure is kept in all the different adaptations, but I think as the other people talk about, based on your local context and your community-specific needs, there are a lot of unique things that we can adapt and apply to it.
So you need to show the video.
Yeah, so we have one more thing to share with you. One of the exciting things is that some of our participants had already has different follow-up groups actually. So people themselves spontaneously connect and form working groups to develop projects that they're interested in championing in the communities. So one of the projects is to produce some of the anti-stigma educational materials for our community. So we are very proud to show you a very short video that our participants have produced that talks about CHAMP and their experiences.
Yeah.